So continuing on with the concept that the board has approved this, um, the paper that I provided for postgraduate continuing education for a particular chiropractic technique called sacro-occipital technique. I'm doing a position paper on it, and I was recommended to do some research on it. I've been wanting to do it beforehand, but the point is that I'm developing a research paper on the effects on this mental model that I have. I'm trying to do a proof of concept, but at a scale, because I've proven it already with patients that I've had, but I haven't had a chance to capture enough data for the people that I've helped. But I can do an anecdotal case study, an N1 study, a study that I learned from Los Angeles College of Chiropractic in Whittier, California. So the president of that college, which has now been grown into what's called Southern California University of Health Sciences, the president of that college was my professor when I was going through chiropractic college. And he's the one that got my paperwork, my outline of what my course is, because it is a course that I teach, and my course that I teach is a threefold model for a chiropractor to position himself correctly into the commercial mindset of the public, that they're sleep and airway space practitioners, but deal with biomechanics only, nothing else. But they know almost everything else that's associated with, but their lane is biomechanics. And so these chiropractors learn from this academy that's been created. It's called Chiropractic Sleep Academy. And Chiropractic Sleep Academy is showcases the best of what chiropractors' opinions are about sleep science, biomechanical sleep science, and biomechanical airway space science. And it's a container for postgraduate education, postgraduate training and certification, and identification that a particular chiropractor sees beyond just the spine. They see also a skull, plus everything else in the body, like arms and legs and pelvis. So a whole holistic approach, biomechanical approach to from a chiropractor is what this is. My course teaches it. It teaches it from 3 levels, 3 modules. The first module is the anatomy of the biomechanics. And you can't necessarily have what you call that in anatomy, you have a structure. You can't have structure without function. So with function, we're going to talk about physiology. So anatomy and physiology is in module number 1 of what I teach, with the biomechanical sciences of sleep and airway from a chiropractic perspective, a California chiropractic's perspective. Now, that being a thing is, we're going to call that clinical. Clinically, I will teach like academic style, like classroom setting, the anatomy and the physiology, to remind the chiropractor that they already know it, but once I put it in order, it kind of does something, and a chiropractor can see a chiropractic patient being a sleep patient also. So teach them the academic anatomy and physiology. And then by teaching them that, it would also be applied anatomy, applied physiology, which is kind of what we teach in applied kinesiology, which I am a doctor of chiropractic and I am an applied kinesiologist. My kinesiology is focused on applied kinesiology's volume 2, called Head, Neck, and Jaw. And at my early onset of my career, I had both applied kinesiology certification and after school mentorship with a chiropractor who was both a chiropractor and a dentist. So for 26 years, I've been doing head, neck, and jaw. And in those 26 years, the last 13 have been in sleep and airway space. My best friend from the Marine Corps, where I served after I served in 4th Force Recon, I served in 3rd Anglico, and I got my gold jump wings. I also got my lead Army wings, but I got my post lead Army wings. I got my Marine Corps gold jump wings. So yes, airborne. Although, military career, I bring that up only because of the discipline that's got me to the point where I can build up this mindset of a neuromusculoskeletal patient being also a sleep patient for a doctor of chiropractic, who can actually merge their business and refine their practice in sleep and get better results for all the musculoskeletal modality treatments that they do to a patient, doing it with just doing it without sleep and without looking at airway space is not sufficient anymore. After you've been showcased that I teach anatomy and physiology in Module 1, Module 2 will be how to learn the vocabulary of sleep that other professionals that are in sleep speak like, and learn the vocabulary of airway space and what the other providers in airway space speak like. So you got to learn this language, which is called clinical language, and clinical language applicable to a consultation or an initial exam or a re-exam, and a report of findings, and then a case presentation and case closing and case collection. So that's all packaged in module number 2. Module number 3 is how to position and brand your particular sleep medicine in your practice, in your community, and on the internet. And so this is what I showcase to doctors of chiropractic, and I certified them being a doctor of chiropractic within the Chiropractic Sleep Academy. So then you can be confident that they have access to the knowledge of the anatomy and physiology. They've been told how to speak to the patient and to other providers and play in the sandbox called sleep apnea, all together nice and friendly. But what I've realized, we kind of sometimes don't play nice. So there exists this control tower, kind of like an airplane control tower. And when all the airplanes start flying in, and for example, an airline's called snoring, or an airline's called sleep apnea, or an airline called insomnia starts flying in, they land first in my office, either in Los Angeles, where my sleep center is, in the San Fernando Valley called Northridge, or they go to my satellite office in California, just near the border of Nevada, where Las Vegas is. So to get to it, you'd fly into Vegas, get shuttled from Vegas to the hot springs about an hour and a half away, which is an area in the desert just outside of a national park called Death Valley National Park. Where you'll be staying at is a hot springs called Death Valley Hot Springs in the city of Tecopa. And the proprietor there will help you out, and I will connect the liaison there, because that's where most of my time is spent. That's where my treatments will be. The treatments will be done by soaking in the hot springs. And there's ways that we will tell whether the person's ready or not, how they can handle the heat of the water, because the elements are not only the elements or the minerals of the water, but also the heat and the source of the heat and its effect on bones and bone marrow. So soaking in there for 2 days. On the second day, we do the treatment, and if necessary, a third day is scheduled, because third day is either recuperation, and you definitely need leave on the 4th day. So 4 days at the hot springs, and the first day is prep day. Second day will be right in the morning, a treatment, and then at the evening at sunset, before sunset, will be another treatment. Then there's sleep time. Do it again the next day, AM appointment, PM appointment. That will be done to the viscerocranium, the visceral airway expansion technique that I do with my thumb in the roof of the mouth and through the nose with the balloon, to adjust the palatine bones, to adjust the maxillary bones, to do maxillary expansion, and to do palatine articulation. It's the sandwich bone between it and the sphenoid, and those articulations. So maxilla palatine sphenoid articulation chain, kinematic chain, because it's a reset area for both headquarters that are microneurology of centers that are like headquarters for the inspiration, expiration. They're also headquarters for waking and sleepfulness. Like one of them is called pre-Botzinger nucleus, which is critical to know about. Those, I believe, if the decompression of a nerve concept is real, that they get decompressed. And what they innervate to is the hypoglossal nerve called cranial nerve 12 to the tongue, which is now you're closer to the cause. It's not the meat muscle that you need to move forward with an oral appliance only. You also recognize that it's a piece of meat, so it needs neural control to it. So that neural control, that nerve to the tongue, to the midbrain, inside the skull, will have centers that will control how this tongue moves by itself, left and right, up and down, and how its set point is, how its parking spot is when not talking, when talking, during sleep, and other types. So that nerve to the tongue could be so-called pinched, kind of like a sciatic nerve can be pinched and cause problems. Well, the problems that a pinched hypoglossal nerve, cranial nerve 12 to the tongue, is like getting pinched, and then now you have a dysfunctioning tongue, drops into the back of the air hole and seals up the passageway from the oral cavity into the lungs, the airspace, the air cavity. We call it the nasopharynx and the oropharynx area. So those are the adjustments that people get. They get adjustments of the bones of the nasopharynx and the oropharynx, but specifically a viscerocranial airway expansion treatment. So with all that being said, I showcase now that the whole program is to start looking at sleep and airway from the perspective of anatomy. And if we look at anatomy, we're going to have to teach anatomy, and it has to be understood by the patient that's looking for an anatomical correction to their sleep apnea, because they might eventually, through my videos, recognize that their sleep apnea is musculoskeletal based. And that musculoskeletal based part needs to get handled. So then things can either be discovered called hypopnea. So hypopneas are like an apnea, but they're calling it a low volume. It's kind of associated with mouth breathing. And you can learn what James Nestor says about mouth breathing. Now, you have mouth breathing happening. You can also have what they call central sleep apneas, which are brain-related issues. Well, there's a part of the brain called cerebrospinal fluid, and that's the fluid that I'm talking about. That's the part that I'm showcasing. Chiropractors of old used to call it liquid light. They considered that when under a black light, it glowed. Whether that is true or false is yet to be discovered. I have people saying sometimes yes, sometimes no. Time will tell. At any rate, the cerebrospinal fluid, we do know, has neurotransmitters in it. Neurotransmitters. These neurotransmitters are, you can look at them like pre-hormones. Before it's a hormone, it's a neurotransmitter. Examples of a neurotransmitter would be something like melatonin. Now, some of these neurotransmitters are secreted by a gland that's talked about, called the pituitary gland, which is right in the middle of the skull. And a lot of people think it's the pineal gland. It's not. I'm not talking about the pineal gland. I'm talking about the pituitary gland, which is like a peninsula of the brain. It's like a Florida. Florida is a peninsula. The pituitary gland is a peninsula of the brain. They're calling it half gland, half brain, probably because of the embryological structures that it came from, the different embryological germ layers. At any rate, the front part of the anterior secretes different kind of neurotransmitters than the posterior kind of neurotransmitters secreted out of the posterior gland. They all secrete neurotransmitters into the cerebrospinal fluid. Now, the cerebrospinal fluid is fluid that is generated by the fourth ventricles, which are kind of like these cavities in the skull that are lined, and the lining secretes the liquid, which is under a tight, solid hydropressure. So it's a closed liquid system, and it's mediated, more likely than not, than what's meant when God created Adam out of the dust of the ground. He breathed into his nostrils and he became a living being. That beingness, that aliveness, is what keeps that cerebrospinal fluid under tension. It's under constant tension. And movements of it sometimes get affected and misunderstood as only neuromusculoskeletal, when it's actually not even fascial, it's dural. So the dura is intimately associated with the cranial bones. Inside the sutures of cranial bones, you find dural tissue when you study it under magnifying glass. Especially, you can learn it if you go see Dr. Mark Pix, who's a chiropractor, but he's a SOT teacher and practitioner. He's also has his own lecture annually in Hawaii on human dissection, if you want to remember, chiropractors, what that looks like when you first walked into chiropractic college on the first day and did dissection. You also, if you remember, moved into histology. So the histological part will be the inner brain cells that will be part of cerebrospinal fluid. And there's a cell in there that science currently right now has a topic that's hot. It's called the glial cells, and they make up the glymphatic system, not the lymphatic system, but the glymphatic system. And this glymphatic serves as a washing of neurological activity debris of the day. And it's done during night when the body's more parasympathetic dominant than sympathetic dominant, and it starts to secrete parasympathetic neurotransmitters, which it can't do unless it's more parasympathetic dominant. At least some of them can't. Nevertheless, these glial cells wash the cerebrospinal fluid of neural activity of the day that was done by that particular brain. It washes it. And so now you're ready for downloading it, because I guess the residue stays in there somehow because it's connected to now locking in memory of the experience. Now, if it washes it away, it's now into memory, or maybe even the reticular activating system before it's parked into long-term memory. I don't know if my neurology is true, what I just said, but it's something like that. So I'm pretty sure it is, but it might be a refined way of saying it instead of saying it like caveman style, like I just did. But the point is this, is that cerebrospinal fluid is washed nightly by a cell called the glial cells, and the cerebrospinal fluid gets washed because of the glymphatic system, so it can start to download the activity of the next day and record it and keep it in the cerebrospinal fluid as current, maybe reticular activating system juice, where it gets its impulses from that's being stored in the juice somehow. Chiropractors of old used to call that cerebrospinal fluid liquid light. They also called it sacred juice. At any rate, call it like it is, still cerebrospinal fluid. And what a chiropractor does is needs to recognize that the viscerocranium doesn't have cerebrospinal fluid flowing through it as much as it does and is associated with the neurocranium. So the neurocranium is cerebrospinal fluid based. The viscerocranium will be airway based, breathing based. Okay. Affiliated with breathing and sleep, and there's a little connection from the pre-Botzinger nucleus, let's just say, and other cell nuclei that's microneurological that is associated with breath and airway and sleep. And it somehow has its interconnections neurologically to the neurocranium, to the cortex. And the fastest way between the two is through the cribriform plate through smell. It's the quickest way to the central nervous system and into the cerebrospinal fluid. So that passageway, we can talk about in another video more in depth. Going back to the modules, there's the anatomy physiology model, there's the clinical how to speak to a patient model, and then there's the monetization model of how to sell a case to a patient after you spoke to them and after you understood the anatomy and physiology, and recognize that this niche of chiropractic business doesn't require many visits, and yet it gets paid more per visit than chiropractors have known to do. Traditionally, we've been paid single digit per visit, or per adjustment, you would want to say. Double digits, some people get into that pricing of double digits per adjustment. Some get into triple digits per adjustment. So what this clinical protocol demands and what the market is paying for is 4 digits per adjustment. So to learn this, it benefits the chiropractor because they're handling a serious problem, because when you don't breathe, you die. When you don't breathe well, you can either stroke out or have a heart attack, because either one of those two, the brain or the heart, not getting oxygen, will have problems. So we adjust the visceral cranium, we adjust the neurocranium and the combo flexion extension between the two using sacrooccipital technique training and education on how that's done. And it relates to pelvic categories. So there's pelvic categories SOT, and then there's advanced SOT, which will be cranial SOT, and then there's extremity SOT, and then there's SOT CMRT, which is chiropractic reflex manipulative technique, which is more organ-based and has been considered called bloodless surgery. So not that many chiropractors do it, know it, and have been trained in it, and those that did are dying off. So it's becoming a lost art. And if you can find a practitioner that does it and does it well, or find a practitioner that knows SOT and knows cranial SOT and wants to do SOT CMRT, that would be the next phase of their career in learning within SOT. So simultaneously, what needs to be understood by James Nestor's audience is that there's another type of a chiropractor called the chiropractor that's been trained in a technique called chiropractic biophysics. Chiropractic biophysics has, within the last 2-3 years, published many, by many I mean maybe 20 plus articles in tier 1 peer-reviewed journals associated with spinal stuff, like spine and a couple of other of the top journals, peer-reviewed journals. Deed Harrison has been published in, and he's been published in there primarily showcasing the effects of chiropractic adjustments upon the whole body, but also the correction of cervical lordosis. Their clinical protocol on approaching a patient who's been x-rayed and it's been discovered that they have hypolordosis, and in the sleep and airway space, they're recognizing that hypolordosis is a causative factor to contributing to upper airway obstructive sleep apnea. As such, CBP has a clinical protocol to correct that within 3 months, requires an SOT practitioner to do work with the CBP practitioner alongside it concurrently. The CBP practitioner can fade away once the correction is completed and the patient continues with SOT treatments. Both decide whether there's value in disc decompression from Disc Centers of America. Now, when the SOT practitioners does the extremities, they have to lock in the extremity connection between the feet all the way to the TMJ to include a pivotal part for forward head posture, which is called lower cervicals. We have in our profession upper cervical doctors. We also have now in existence doctors that emphasize the need of lower cervical, and there's a correlation with forward head posture and arch collapse differences from left to right or from right to left in the feet of the 3-foot arches that exist there, inner arch, outer arch, and arch across the ball of the foot. Those need to get checked out by an SOT extremity practitioner. And in my network is where you can find all these people. Once you've done all the stuff from foot to jaw, you check feet, you check pelvis, you check spine, you check hypolordotic neck curves, you check TMJ, you check cranium, the neurocranium, and you check viscerocranium. You check the viscerocranium for viscerocranial subluxations. You look for neurocranial subluxations. You look for vertebral subluxations, and you adjust them. In the spine, there'll be diversified adjustment, high velocity, low amplitude, or better. But you'll at least get diversified adjustments that you can find at locations called, like, there's a franchise called The Joint. For about $80 times 3, so about $240 to start, plus $80 a month, you can get up to 4 adjustments a month. I have a membership. I go. I keep paying, even though sometimes I don't use it, but I feel for $80, it's worth it because it's worth it. It's worth it to move that company and profession forward, as it is to all the other ones I mentioned, like Disc Centers of America, Chiropractic Biophysics, Sacro-Occipital Technique, Chiropractic Sleep Academy, and my joint ventures called robertzeravica.com. That's where I showcase my whole vision for everything. I hope this helps your audience, James, Mr. Nestor, and I hope that it will generate some kind of feedback to me that some of the things that I'm saying are missing links in people's sleep apnea, because what currently exists is not sufficient. I pick up the insufficiency where it's a gaping hole. It's called biomechanics, but not biomechanics from the dental perspective, biomechanics from the other scope of practice that checks everything else besides biting teeth. It's called the Doctor of Chiropractic. They're a sleep structural specialist chiropractor. They get certified by my Chiropractic Sleep Academy. You can find me at either the Academy's website called chiropracticsleepacademy.net. That's our network of doctors. Or you can find me as a practitioner of what I teach at chirosleeppro.com, or you can check out my personal website, which is my name, robertzeravica.com. At any rate, the offer is that we start at the hot springs, 4 days, minimum 2 days. We start and we unlock the door into biomechanics by adjusting the viscerocranium, the hard palate, and the nasopharynx, plus the rest of the body. And then we follow up with the CBP SOT concurrent treatment for 3 months. And then we meet up with the dental CBCT machine that we've taken a before picture at the beginning of the 3 months. We're going to take another CBCT. That's a cone beam CAT scan. It's like an X-ray, but 360 degrees around you that doesn't only just see teeth and bite, sees head, neck, and jaw. And it outlines airway space, and it colors red space that's below normal, red. And if it's normal, it's green. And if it's kind of compromised, it's yellow. So it gives you a color coding from your nose through to your lungs in the passageway that make up the head, neck, and jaw. Before and after images of that is my clinical protocol, that this is my movement that I'm asking help for. I'm asking for people that have failed CPAP machines to connect with me. I'm asking for people that have had failed oral appliances connect with me, because they probably failed, not because they're not good. I'm certain that they're good because the concept's good. What they are is they are insufficient. CPAP alone is insufficient. Oral appliance alone is insufficient. Where you got to start with is where applied kinesiology teaches, which is with structure. We monitor biochemistry, and we teach a new mindset that there's biomechanical sciences in sleep and there's biomechanical sciences in airway. I really should start to talk more about... Okay, so I'm going to shift a little. I'm going to kind of talk about my whole thing, which is what I talk about during my continuing education lecture to Doctors of Chiropractic. So it's the biomechanics of airway, a skull down approach to sleep, how it integrates something I have as a framework. I call it VAET, but I also call it VANI-R. I'll get into what those mean, but VANI-R means viscerocranial airway neurocranial impulse and relaxation framework. VAET stands for viscerocranial airway expansion technique. So all of that is fancy words, but it clearly defines what it is I'm trying to say, and that what I'm speaking of is the biomechanics of airway. And it is a skull down approach to sleep for the Doctor of Chiropractic. So has here that I'm the presenter. I'm also the founder of Chiropractic Sleep Academy, but I'm presenting as Dr. Robert Zeravica DC, California chiropractor. So the thing that I like to tell people first is that human performance infrastructure for the AI age is delivered through chiropractic. Now, a human with compromised sleep and airway cannot compete in an AI-accelerated world. That's my quote. Okay? Now, I tell you all this because I stand on the shoulders of many, many, many giants, and I'm trying to honor their lineage of airway and breath. The first one that I want to talk to is someone that is called Dan Murphy. He's a doctor of chiropractic, and he is the current teacher of bilateral nasal specific technique that I have learned. I've also learned chiropractic I've also learned craniofacial release. So I've learned both techniques, and I'm certified in both. In one of them, I'm an advanced elite practitioner, or was. The other giant, a category of giants that I stand on, is who this video is for and who he's showcasing my message to his audience, and that's James Nestor, who I've learned a lot from, and how he teaches has really improved how my body composition is and my overall health and energy level. The third category are clinicians. My first mentor is my applied kinesiology, the creator of it, Dr. Goodhart. He was my doctor. He adjusted my cervical spine. He taught me in lecture. He I had a diplomat get me certified in 100 hours called Dr. Robert Blake. They know him as Bob Blake. He's a chiropractor and an applied kinesiologist and a diplomat in applied kinesiology. All three of us, Dr. Goodhart, Dr. Blake, Dr. Zeravica, that's me, have utilized the textbook written by another chiropractor called David Walther. His book is called Synopsis, and it's Applied Kinesiology Synopsis, or Synopsis. I forgot which one the title is. I think it's just Synopsis, but it's done and distributed by the International College of Applied Kinesiology, or some link like that. And he also created this volume 2 book called Head, Neck, and Jaw, which is what I got excited about and mastered. And the mastery of this, what he calls the stomatognathic system, I'm expanding to being called the holistic stomatognathic system. So being a master of applied kinesiology and the stomatognathic system, which is the head, neck, and jaw. My mission in all of this is to synthesize all these masters into a cohesive clinical reality for the modern chiropractor. Now, my skull down philosophy is this, that bones don't narrow, tunnels do. And tongues don't enlarge, oral cavities collapse. So what it is it's a geometrical and structural approach to airway obstruction. There's a diagnosis, they call it UAOSA, and it stands for upper airway obstructive sleep apnea. Now, it is a geometry problem. And in high school, I love geometry, so that I get to apply that to the skull and to the fixing the problem called sleep apnea, or specifically upper airway obstructive sleep apnea. It's about the shape and the volume of the viscerocranial tunnel. So my skull down logic, which is that the state of your skull or the state of your cranium dictates the state of your spine. So under my skull down philosophy, this third category, which is my technique I told you earlier called Viscerocranial Airway Expansion Technique, or VAET, is a standalone solution and compared to everything else. So compare VAET versus everything else in this vein or this light, that VAET doesn't just open the nose, we reshape the viscerocranium to change the tunnel geometry. So the mission here is the synthesizing all these masters and all these techniques into a cohesive clinical reality for the modern chiropractor. Now, there are 10 hidden causes of upper airway obstructive sleep. There are basically 10 hidden causes of upper airway obstruction that every chiropractor misses. I'll give you 5 of them, okay? One is the hard palate, the roof of the mouth. We're going to call that the palate. You can have palate stiffening. So that can have mechanical compression on the neurology, the microneurology, the brain neurology, the little spinal tracts. One of them is called SPG, sphenopalatine ganglion. We'll get into that later. There's also a second cause of hidden upper airway obstruction that every chiropractor misses. It's called the hamulus distortion, okay? This is a mechanosensory tripwire that is a course in and of itself. Hamulus distortion. When you look at the roof of the mouth and you ask the patient to open their mouth, you'll see a lot of things, but you'll also see the soft palate. We're going to call the muscles that lift and lower those called elevator. So they elevate. So veli, I think, is elevate. Maybe I'm wrong with that. But tensor veli palatini, okay, TVP, weakness, which is a trigeminal problem. Trigeminal nerve, a cranial nerve. And it's not just a muscle problem of the soft palate. So it's not just breath work or speech therapy, myofunctional therapist work problem. It's a trigeminal problem. Those are the 10 hidden causes of That's the third of the 10 hidden cause of upper airway obstruction every chiropractor misses. The fourth one that I want to bring up is the eustachian tube ventilation failure, the ear breathing connection. Okay, so on those charts that you see or models that you see, always have the eustachian tube going away from the ear and into this nebulous black hole. No real known books and anatomical structures showcase where the eustachian tube ends and what structure it is where it ends. What kind of a structure is it? Is it either muscle, bone, or nerve, or something else in the musculoskeletal system? And it doesn't showcase what's at the end of it. So 3 things. First of all, it's cartilage, like your nose. That's how the eustachian tube end is. That's why when you move your jaw or decompress from high altitudes, you can kind of start to feel that it's cartilage that you're stretching out to cavitate that decompression between the exterior and interior. The other thing is that at the end of the eustachian tube is a torus-like structure, and what needs to be understood is what a torus structure is, but the torus structure is at the end of the eustachian tube. And doing an intraoral digital examination and palpating it by swiping it, it's probably kind of done like, it can be done with different fingers, but it's a swipe, and it's supposed to be kind of like if the drain is clogged, swiping it opens up the drain so it can start to drain. That's been a known chiropractic technique that when chiropractors of old were known for ear infection helping, they got labeled as quacks because that wasn't their territory, because they didn't know how to speak the anatomy and physiology. They didn't know how to do initial exam or re-exam with sleep and airway, didn't know how to connect at all. Until now. I'm going to move beyond the eustachian tube ventilation failure as a cause to the 5th cause of the 10, and then I'm going to go on to something else. The sphenoid torsion, the locking of the cranial pump, is the main hidden cause of upper airway obstruction every chiropractor misses. Now, the missing link is the the missing link is the viscerocranial cervical integration, meaning how does it connect from here to the skull, to the spine, to the cervical spine. So we got to look at what the ENT medical doctor looks at is tissue, mostly soft palate and tonsils. The dentist looks at the teeth, and their choice treatment is mandibular advancement. Some are getting into palatal expansion. Both are what they are, but the chiropractor looks at the system, the feet, the pelvis, the curve, the spine, the cranium. And overall, what unlocks an ENT medical doctor, what unlocks a dentist, what unlocks a chiropractor is a secret. We call it the secret. You cannot expand a cranium that is locked by a twisted tail, as in SOT teaches, or a kinked hose, as in CBP teaches. Again, the mission here is to synthesize all these masters in chiropractic into a cohesive clinical reality for the modern chiropractor and for the benefit of the patient. So we got to go into what's called phase 2 of upper airway obstructive sleep apnea and what it's not. It's not a tongue problem. It's beyond the tongue. It's the TVP, the trigeminal connection. And the goal with this is to challenge the most common myth in sleep medicine and pivot to neurology and geometry. So the tongue is a symptom, not the primary cause. The real culprit is the tensor veli palatini. Okay? What's also connected with it is the neurological component. The TVP, the tensor veli palatini, is innervated by the mandibular nerve, V3 of the trigeminal nerve, the cranial nerve. So, in addition to that, how UAOSA, or upper airway obstructive sleep apnea, is not a tongue problem is that the geometry. If the palatine bones are tightened or the hamulus is distorted, the tensor veli palatini loses its mechanical advantage. So the solution, the VAET solution, is to restore the house of the TVP to restore its function. So again, the mission, synthesizing the clinical chiropractic masters into a cohesive clinical reality for the modern chiropractor. So speaking of the other acronym that I've generated called VANI-R, V-A-N-I-R, and the logic behind it. So the logic, the clinical juice of how results can get better is timing, but logic. So, and order, relaxation before expansion. And that's generally not thought of or done by the doctors, the dental doctors, when they do their oral appliance expansion. But they're changing and getting better because they're collaborating with Chiropractic Sleep Academy and providers and practitioners within it that focus on the biomechanics of sleep and the biomechanics of airway. So again, showcasing that VANI-R, the order of operations, is the goal is to explain my proprietary treatment sequence, which is viscerocranial assessment and identifying the geometry. That's the V. The A stands for airway drainage, clearing the so-called, quote, plumbing before we do the, quote, wiring. That's the A, so airway drainage. The N-I, the NNI is for neurocranial impulse and restoring a divine rhythmic drive called PRI, or primary respiratory impulse, and there's primary respiratory mechanics behind primary respiratory impulse. And we'll get into that into a video module called primary respiratory impulse. Moving on into the letter R, which is the relaxation part, is if the system is in sympathetic high guard, it will resist expansion. So we try to get the nervous system into a more parasympathetic dominant state than sympathetic dominant state, especially during REM sleep and lower. So the rule with this logic is you cannot force a skull to open if the nervous system is trying to hold it together. So the foundation is this, that there's an ascending kinetic chain. The foundation. Why do feet dictate the airway? The goal is to bring the Foot Levelers data. Foot Levelers is a company that provides a service to the Doctor of Chiropractic related to the feet. Some clinicians have a clinical problem with their product because maybe they know something advanced that doesn't need, that product is not needed for that particular patient. They feel that most of the time it does not. Sometimes they even feel that it could be bad to do. There's all controversial stuff, but the science behind what this company teaches, Foot Levelers, is what's important. And the chiropractors that are involved with it at least look at the feet. So for the time being, they're the leaders. So the goal is to bring in the Foot Levelers data and show how it affects sleep and airway. And how we start with is with collapsed arches, and they call that pronation of the arches. That starts to do an internal rotation of the bone of the leg below the knee and affect the angle that it hits and makes contact with at the knee joint with the bone that is the bone from the knee up. So the combination of internal rotation happens and affects the knee from collapsed arches of the feet, which causes an anterior pelvic tilt. And an anterior pelvic tilt is when the low back is kind of arched excessively. That's an anterior pelvic type tilt. And what that contributes to with the psoas involvement, both left and right, which are front low back muscles connected to the front of the spine, that they contribute to what's common in society today called forward head posture, or we call FHP. And FHP is now known in the sleep, apnea, and airway space field as airway narrowing of the oropharyngeal space. So what they term forward head posture, clinically it's known as a hypolordosis. And as I said earlier in earlier videos, Chiropractic Biophysics showcases how to address forward head posture. They've been showcasing and been having articles published in tier 1 journals in the biomechanical industry, like Spine Journal, As Such, and Better. So, talking about things is there's this thing called the buckling effect, going back to the collapsed arches. They said earlier, like they do internal rotation of the tibia and femur, and they cause anterior pelvic tilt. The compensation is to keep the eyes level, and the body creates forward head posture. Forward head posture pulls the hyoid bone back and narrows the oropharyngeal space. So, chiropractic fact, you cannot hold a skull down adjustment on a feet up collapse. So, there it is. So, what Foot Leveler's 3-arch model is, it's stabilizing the back wall with known as the 3-arch advantage for the airspace in the throat. So the goal is to explain why specific orthotics are clinically necessary in Chiropractic Sleep Academy's protocol, or in the protocol of a patient that wants to run a holistic biomechanical protocol for sleep apnea, upper airway obstructive sleep apnea. So general orthotics only support the medial arch. It's one-dimensional. Foot Leveler supports the medial, lateral, and metatarsal arches. The result is that there's a balanced pelvic height and reduced dural torque. So balanced pelvic height means that the pelvis is not higher on the left or higher on the right, that it's more balanced. And that reduces torque on the spinal cord exterior that's called the dura. And we'll get into that later, but that's critical to know. So this whole thing isn't for foot pain. It's to stabilize the cervical lordosis or the back wall of the airway. You really need to understand and see the visual of a medial, lateral, and metatarsal arch. Moving beyond that into sacro-occipital technique, and practitioners of the technique and teachers of that technique, they look at the pelvic floor of the airway. The floor is SOT pelvic categories and dural torque. That's when we say the floor, those are the things we're talking about. So the goal is to transition into SOT and explain category 2 instability. So the key to think about this is that there's a twisted tail or a twisted pelvis, and it locks the roof of the cranium. Okay, and the roof of the cranium is part and parcel with sleep apnea. So you have what SOT calls category 2 instability, and those are pertaining to the sacroiliac joints, which are the weight-bearing ligamentous instability joints of the pelvis. Or they're the ligament stability joints of the pelvis. They're known as the sacroiliac joint, or SIJ, sometimes for short, because their Lovett brother is the TMJ, and we'll get into that. So the core link is that the dural torque from the sacrum travels up to the occiput and the sphenoid. Now, the dural panic is that the brain senses the instability and creates compensatory tension in the neck and jaw. I call all this a core link, or the core link. But specifically beyond that, a longer word, I call it the dural superhighway. The core link is that this dural superhighway is sacro-occipital connected. Now, my goal with this would be to explain the mechanical connection between the tailbone and the skull, but a couple of landmarks. Remember that in the cranium, there's something called the foramen magnum, which is the hole at the bottom of the skull that the spinal cord has a hole around. And there's also cervical bone number 1, cervical 2, cervical 3. And then we're going to call S2 tubercle. These are all attachment points for the dura. And there's much more, the inside of the skull, all the way to where the sella turcica is. So here is, I'm trying to explain the mechanical connection between the tailbone and the skull. The dura mater is a continuous, non-elastic sleeve. Non-elastic means it's not flexible. It's not elastic like you have elastic around your waist with your underwear. It's not that way. That dural skin is not elastic. Non-elastic sleeve, um, unlike the skin of a hot dog, which is flexible. So if the skin of the hot dog was non-elastic, not flexible, that would be the dura mater, which is considered and has an AKA of tough mother. So it anchors firmly at the foramen magnum, like I said, C2, C3, and the S2 tubercle. Some have claimed that it's on C1 with some dissections. The clinical reality is this, that the pelvic unleveling, if your pelvis is high on this side or high on that side, it's going to have an effect on the spine, and unleveling it, or if there's sacral torsion, creates what's called a mechanical pull on the occiput and the sphenoid, hence the dural superhighway concept. So dural torque is this tension. The tension reduces the amplitude that the primary respiratory impulse does by locking the cranial sutures. So a concept that I didn't really talk about is the amplitude of the primary respiratory impulse. And we'll get into that into other videos, but that's critical to know about. So we move on to what I mentioned earlier between the sacroiliac joint associated with the pelvis and the TMJ being love-it brothers of each other, or having a love-it brother relationship, which is a mirror effect. And my goal here is to show you that the specific mirroring effect that causes airway failure. So there was a chiropractor named Dr. Lovett, and they call it this way because he discovered that within gait, C1 moves in contralateral rotation to L5, and C2 with L4, C3 with L3, C4 with L2, and so on and so forth till it gets to the middle of the spine. Then they say fine and dandy. Now they start asking, well, what's this TMJ? I mean, what's the love-it brother to the sacrum? Because they stopped at L5, and they said that the love-it brother of the sacrum is the occiput. And the love-it brother to the SI joint is the TMJ, the temporomandibular joint. Now, case to remember again is just to reemphasize is that the SI joint is the primary weight-bearing joint, and the TMJ is the most innervated joint in the body. Some call it TMJ acronym, not temporomandibular joint, but the most important joint. So I kind of agree. So the airway insight is this, is that you cannot stabilize a TMJ or the stomatognathing system if the SIJ or the SI joint is in a category 2 instability. Now, going towards the primary respiratory mechanism, my goal here is to introduce the rhythm of the skull before the expansion of the balloon. The 5 elements of the primary respiratory mechanism and is known and taught by Sutherland, and what's known as inherent motility, not inherent mobility. Not mobile, but motile, motility. That's where the brain and spinal cord move rhythmically. Cerebrospinal fluid flow, the liquid light that clears metabolic waste during sleep, all of this has an airway connection. So if the sutures of the skull are jammed, the primary respiratory impulse is low, and the tissues of the airway lose their neurological tone, T-O-N-E. They lose their neurological tone. So the visual suggestion would be something like an animation or an image of a cranial bone motion during inhalation and exhalation phases. So moving on to what's critical is talking about SOT craniopathy and the stomatognathing system. The stomatognathing system, the head, neck, and jaw, the goal here is to teach that there's integrated David Walther's AK book and his work with SOT craniopathy. So it's a complex integration of the TMJ, hyoid, and cervical spine. TMJ, the joint, the hyoid bone that sits right here, and the cervical spine, which is the 7 neck bones in the neck. This stomatognathtic, what I call a quote box, if the jaw is recessed, then the tongue. But if it's recessed, then the tongue has no room. So the SOT approach is using the intraoral techniques to release the palatine bones and the maxilla. So we transition from the floor, which is the pelvis, to the roof, which is the cranium. Now, when we're at the roof and we're talking about the back wall of the airway space, this is where CBP, Chiropractic Biophysics, and the founder of that technique, or the founder and his son, Deed Harrison, chiropractor of Chiropractic Biophysics, and the airway kink. So using the concepts that he has and aligning that with what's called airway kink. So the goal here is to transition into the cervical curve section that CBP is masters in. So if feet are the foundation and the pelvis is the floor and the cervical curve is the back wall, the kink in the garden hose analogy is loss of lordosis stretches the cord and narrows the tunnel. So cervical hypolordosis is what's called a flat neck curve, is a mechanical airway emergency. So why do traditional, quote, popping by chiropractors won't solve a structural curve collapse? They call a hypolordosis the military neck. So, the visual suggestion is to compare an image of a garden hose with a kink versus a flat cervical spine and a narrowed airway. So, moving into the kink of the garden hose a little bit deeper, the cervical hypolordosis, the kink in the airway, it's to explain why a loss of lordosis is a mechanical disaster for breathing. Normal lordosis, the quote life curve, got this on my desk, it's called keeper of the curve. This life curve that maintains the tension of the spinal cord, this hypolordosis, this military neck that stretches the spinal cord and the brainstem, this mechanical effect, the forward head posture, physically narrows the oropharyngeal space, so mouth downward. So the result, the back wall of the airway collapses inward, leaving no room for the tongue. So something that's rarely connected is whiplash. So traumas and rear end injuries with motor vehicle accidents, chiropractors are known for that kind of treatment. They can incorporate this Chiropractic Sleep Academy knowledge into what they do and recognize that whiplash dynamics and airway collapse are integrated. Trauma-induced airway failure is whiplash dynamics. So the goal here is to connect AK and CBP through the lens of trauma from the whiplash files that the chiropractic industry has. So the whiplash mechanism, in case most don't know it, is it's acute or like trauma right here, right now of hyperextension and hyperflexion. And it tears the anterior longitudinal ligament. That's a ligament at the front of the spine. And that does only the spinal stuff. You got to think about it, what it does to the skull. And what it does to the skull is the whiplash of brain material moves at a different speed than the bony material. And so the inside attachments of the skull to the inside of the bony skull get ripped and torn. So all this results, the body creates a protective splinting, which is a locking the neck in a flat, high guard position, aka military neck. So the AK connection is that identifying the hyoid and the TMJ faults, or the lesions of the TMJ or the lesions of the hyoid that occur during a crash. So the CBP connection is this, is why post-traumatic traction is the only way to remodel the scar tissue. It's backed by peer-reviewed journals, Tier 1 peer-reviewed journals, many of them. Deed Harrison. So the result is that the body creates a protective splinting, locking the neck in a flat, high guard position, as I said, and the AK connection is identifying the hyoid and the TMJ faults that occur during a crash. So the CBP connection is why post-traumatic traction is the only way to remodel the scar tissue. I think I've said that twice, but moving on to what's called airway diameter study. Data-driven correction. That traction increases volume. The goal here for me to teach you this is to provide that the hard data that proves why chiropractors are essential, and we get this from CBP files. So the study is to correct the correction of cervical kyphosis to increase the oropharyngeal airway diameter. The evidence, every 10 millimeters of forward head posture correlates with the significant reduction in airway volume. So the power of traction, moving the head back over the shoulders, increases the diameter of the back wall. So what CBP also brings to the table is called mirror image adjusting versus what's called so-called, quote, the pop that you hear when you get an adjustment. So mirrored image adjustment versus the pop. It's pretty much mirrored image adjusting beyond the pop. So the goal here is to explain why specific chiropractic biophysics adjusting is different than general manipulation or general adjustments or diversified adjustments. So I'm going to say instead of general manipulation, I'm going to call it diversified adjustments, called the pop. Bones move temporarily, whereas mirrored image adjusting remodels the system with structural and neurological change. It overrides the new normal, which is a collapsed state, and it creates a corrected normal, a new set point, is sometimes what I call it. So CBP and SOT integration is the secret sauce. It's the double lock release. So it's integrating CBP and SOT. And the goal here is to show you how to combine these systems into a single session. So CBP cervical traction with the Denerol at minimum. Dural torque release, which is the core link, and SOT pelvic blocking. So SOT secret sauce is the protocol is blocking the pelvis, SOT, while patient is in cervical traction, CBP. The core link release is that this release dural torque from both ends simultaneously. The preparation, though, this is the ultimate pre-CFR setup or pre-BNS setup or starting my VAET technique. So the result is that the system is relaxed and ready for VAET expansion. There it is. So CFR and BNS are within the VAET protocol. So case study for military neck to deep sleep, the power of the back wall. My goal here is to show a real world win from my case library. So before, they had a military neck and high forward head posture, an anterior head, forgot what the I is, of 28, probably 28 millimeters. Patient is a 45-year-old male, and the problem is that they have a 4-inch forward head posture, a military neck, and an AHI of 28, moderate apnea. So with foot levelers, SOT, and CBP traction, the protocol 12 weeks of foot levelers, SOT, and CBP traction, there's a significant AHI reduction from 28 to 8. Well, that's the apnea-hypopnea index. And the result is that there is a 2-inch reduction in forward head posture, and the AHI, again, dropped to 8, normal sleep. So the triad of health is the airway triangle. I call this the airway triangle, the triad of health, why structure isn't everything. The goal here is to frame the applied kinesiology philosophy of a multifactorial cause of apnea. So we can start with structure, which is the physical box, the feet, the pelvis, the spine, and the skull. So AK's insight is if you fix the structure but ignore the chemical inflammation, the airway stays swollen. So the chemical aspect of this is taught in the anatomical part, which the flip side of the coin would be to teach physiology, which is chemistry, which is the biochemistry, which talks about things like cortisol spikes, adrenal fatigue, or the water-salt balance. What I call all that is AWSO. I'll get into that. That's critical. That's at-home, stay-at-home program. That's part of the stay-at-home program. The third part of the triangle is the mental-emotional, the sympathetic high guard state that locks the sutures. So in AK, the head, neck, and jaw is considered a stomatognathic pump, and it's a gateway to the brain. The goal here is to explain the relationship between the jaw and the cranial pump. the complex relationship between the TMJ, hyoid, and cervical spine. Also, what I do want to demonstrate is that how the jaw-cranial link exists, so jaw-cranial. Every time the patient swallows or chews, they are supposed to pump the cranial bones. The stomatognathtic distortion, if the jaw is recessed or the hyoid is pulled by a flat neck, the cranial pump fails. The result is stagnant cerebrospinal fluid and a collapsed airway. So the visuals really tell a picture, and you got to just see them. Moving on to the maxilla, which is going to be the roof of the mouth, which I call the airway geometry bone. The goal here is to identify the primary target for expansion from my maxilla file. So the maxilla forms the floor of the nose and the roof of the mouth. And the geometry is the volume. So if the maxilla is narrow, or what they call a high arch palate, the nasal airway is physically restricted. There's also a sphenoid link. The maxilla articulates with the sphenoid, but it articulates also with a maxilla-palatine sphenoid connection too. So if the maxilla is jammed, the cranial engine, the sphenoid, stops. Maybe stops is not good enough word, but it changes in its function. So the VAET focus is we're not just opening the nose, we're remodeling the maxillary base. And with that comes palatal stiffening, the SPG house, or the sphenopalatine ganglion. So this lives in the pterygopalatine fossa, which is critical. It's like right in this area deep in the middle. So this explains what's called a missing link that's found in my palatine module. So I've got a whole module on the palatine bones that is critical to understand. So mechanical compression of the SPG, or the sphenopalatine ganglion, a neurological tissue, it creates what's called a mechanical squeeze, where these bones stiffen or tighten and they compress the house of the SPG. What the result happens is the autonomic dysfunction, dry airway, and poor mucosal clearance happens when you have palatal stiffening due to the SPG ganglion location. Now, going back to the tensor valli palatini, which is the soft tissue curtains of the back of the throat where the uvula hangs from, that thing that's dangling in the middle of the back of the throat, and the trigeminal nerve, three branches, forgot how they do that, V1, V2, V3. So, and the palatine hamulus. Okay, so the hamulus is a mechanosensory distortion point. So the goal here is to bridge the neurology of the soft palate with the mechanics of the skull. So the muscles that pull up the soft palate, called the tensor valli palatini, loops around the medial pterygoid hamulus. And the mechanism that the TVP acts like a pulley to tension the soft palate, the distortion happens when the hamulus is mechanically shifted, the pulley fails. And the neurology is that the V3 part of the trigeminal nerve and the feedback loop it gives and the adaptation because of what's happening there is being reported to the cortex. So this is why the soft palate collapses. The pulley system is broken. The palatine hamulus. Secret sauce stuff. So the transition, the drainage before expansion, okay? What to do before you do the ballooning expansion technique is you drain first. Drain before expansion. Drain before force. So to set up the main event, the ballooning, the craniofacial release, or the bilateral nasal specific, is by emphasizing the need for preparation work. So my rule, the viscerocranial airway expansion technique rule, is you cannot expand a system that is backed up. You must clear the lymphatics and the eustachian tubes first. Then you prepare the mucosal shield, immune capture and clearance, and you can run my protocol. So reshaping the visceral cranium beyond nasal opening to define the proprietary therapy as a structural remodel, not just a nasal adjustment. The viscerocranial airway expansion therapy, a multidimensional structural remodel. The difference here is that the nasal strips pulls the tissues, ENT cuts the tissues on the inside, but my VAET reshapes the bone. So the goal is to restore the airway geometry by mobilizing the sphenoid, the ethmoid, and the maxilla, and the palatines. So the outcome is creating a self-sustaining patient airway, creating a self-sustaining patient airway, creating a self-sustaining patent airway that stays open without crutches. So the mechanics of the balloon. So the endonasal Invisalign for the skull, you can call it. I don't know if I'm doing a copyright there. If it is, just bleep that part out. Use another word. So the goal here is to explain the physics of the endonasal procedure. The balloon acts as a centrifugal force from the inside out as it expands. And the target is the nasopharynx. 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 And the articulation of the sphenoid, which is a central skull bone. Center skull bone. Mobilizing this is breaking what's called the static lock of the cranial sutures. And this neurological reset, this sudden expansion, triggers a mechanoreceptor response in the V3 trigeminal nerve. This causes what's called ear breathing, the eustachian connection, eustachian tube connection. Ear breathing is a new concept in ventilation, and ventilation and respiration are differentiated completely apart from what's called breathing. So, speaking of ventilation here, is the goal is for me is to introduce you to your ear breathing concept. And you can get this from my files, my modules on ear breathing, but an overview here is that the discovery is that the middle ear ventilates by way of the eustachian tube through the nasopharynx. So biblical nasal breath is true nasal breathing pressurizes the eustachian tube. So the VAET impact is that improving the geometry and the neurology of the eustachian tube ventilation. So better ventilation equals better immunity. Restoring the mucosal shield of the inner ear is what this is kind of assisting. Now, the concept that the cerebrospinal fluid is being liquid light is controversial at this point in time until proven otherwise. I'd love to know. But CSF and glymphatic clearance is what I'm talking about next. And the goal here is to explain the deep physiological benefits of open airway sleep. And you can get that more details from my files. But people have known what's called the lymphatic system, but I'm going to add a G in front of it and call it the glymphatic system because I'm a G. No, I'm just kidding. The glymphatic system is like the lymphatic system, but it's got a G in front of it because they're from glial cells that are in the cerebrospinal fluid. And this glymphatic system is the brain's waste clearance system that only turns on during sleep. That right there is new science, okay? And that it is the brain's waste clearance system. So I'll get more into that later. It's quite phenomenal. But the pump, the cerebrospinal fluid, the liquid light must flow rhythmically to wash the brain of metabolic toxins, like what they call a protein called amyloid beta, or another protein, they call it a tau protein, TAU. So the obstruction is that the apnea and cranial locking halt the pump. So apnea and cranial locking halt the pumping of cerebrospinal fluid. So the VAET result, my technique result, is restoring the primary respiratory impulse called PRI and turn the wash cycle back on. So nasal strips versus my technique. So nasal strips are like an external pull. VAET is an internal expansion. The goal here is to prove why my structural method is superior to temporary fixes like nasal strips. So nasal strips pull the soft tissue open. They're temporary, they're external, they're a band-aid problem. They don't address the underlying maxillar sphenoid restriction. The VAET advantage is we teach the airway to open itself from the inside out, reshaping the tunnel. Permanent change versus nightly reliance. So the mucosal shield, another concept, the mucus that's found in your nose going backwards, that's always liquidy, and what that has to do with your immune integrity. So the mucosal shield is the airway's immune shield. So the goal here is what I'm trying to do is to connect breathing to the immune system, and you can get more in that from my VAET immunity files. But the mucosal capture is a patent airway. That means open for airway flow, not closed. Allows for proper filtration and clearance. So the VAET benefit is that improving the geometry allows the cilia to move the mucus more effectively. The results is that there's better immunity and there's reduced chronic ENT infections, ear, nose, throat infections. Airway patency is the first line of defense for the immune system. So going back to the SPG house, which is the sphenopalatine ganglion, and releasing the concept called releasing the autonomic switchboard. So when you release a switchboard, and this switchboard is based not on what's called the conscious part of the nervous system, called the central or peripheral nervous system. They're calling this the autonomic nervous system, which coordinates and does actions like blinking and heartbeat. So the sphenopalatine ganglion, found somewhere right in through here, but right in the middle, in between those two areas, right in the middle of the skull, middle of everything, a little bit lateral from midline. So the goal here is to explain the neurological benefit of releasing the palatine bones, which are the bones that make up the posterior part of your hard palate. So the sphenopalatine ganglion is the largest parasympathetic ganglion outside the brain. So this regulates lacrimation, nasal mucus, and the swelling of the airway tissues. The problem with this is that mechanical compression of the pterygopalatine fossa, the SPG's house, has an effect on the SPG. So mechanical compression of that fossa causes problems in the SPG house. So the solution is the VAET solution, which is ballooning creates space in the fossa, allowing the SPG house to regulate the autonomic tone of the airway. So moving on. So sometimes understanding how cranial bone motion moves, the primary respiratory impulse, the primary respiratory mechanism, we got to recognize a study called the cranial kinetogram. The cranial kinetogram is visualizing motion. It's mapping internal motion. It was a test done. The goal of this was to provide a visual language for the movement of the Chiropractic Sleep Academy, the biomechanics behind sleep and airway space. So visualizing the spheno-occipital flexion and extension, identifying the static locks in the viscerocranium, I call them the viscerocranial subluxations, knowing that the cranial pump is a thing and that the stagnant skull is a thing too. So they use the kinetogram to explain the before and after of VAET expansion, where they put electrodes and through infrared started to measure some kind of movement. They called that the cranial kinetogram. So moving on to something else that I got a goal to teach, which is a hands-on demonstration, the skull walkthrough. Well, through this video, it might be hard to do, but I'm going to at least explain how it's done. And what's going to be demonstrated is what's called the viscerocranial expansion. The goal of this is for about 10 minutes, I would interact and show you what to do. But since we're not with each other, I would tell you that I would do these 4 steps. So I would palpate the maxilla and palatine sutures. So get out the books and look where those are. Step 2 is to identify where the hamulus is and testing the tension of the tensor veli palatini, or the soft palate veil where the uvula is. So step 3 is the balloon vector and showing the path through the lower, middle, and upper meatus of the nasal cavities, 3 on each side. And step four would be to do the sphenoid release, visualizing the unlocking the cranial engine. So VAET protocols, the clinical sequence, is a 4-step protocol. The goal is to give the recipe you can take home. So 1, 2, 3, 4. Cranial drainage is 1. Hinge release is 2. The expansion with the balloon is 3. Number 4 is the neurological integration. So talking about the cranial drainage, that's clearing the lymphatics and eustachian tubes. I also use ozone. I pipe it in through olive oil so it becomes ozonol, and pipe it in through the ears through headphones that are tubular. Clearing the lymphatics and the eustachian tubes, and ozone treatment, intra-auricular. The hinge release, which is manually mobilizing the palatine and maxillary sutures. And then the expansion, the precise endonasal inflation based on the kinetogram motion. And the neurological integration is the post-inflation treatments and rest to allow the V3 nerve to reset. So VAET as a standalone solution versus integrated when the balloon is king. So the goal is to emphasize that while the kinesiological chain matters, the balloon is the special sauce. So in acute cases of upper airway obstruction, UAOSA, the VAET is the primary driver of change. So it's the final bottleneck, and it's the primary driver. So while you'll also need to clear the feet and the pelvis, the viscerocranial tunnel is the final bottleneck, but it's the start bottleneck. It's not the final. It's the start of the release of the bottleneck. So VAET changes the tunnel geometry when everything else has failed, or it changes the geometry as a first-line approach to approaching upper airway obstructive sleep apnea. So it is the missing link for ear, nose, throat doctors, dentists, and traditional chiropractors. So the Academy lifestyle, the Chiropractic Sleep Academy lifestyle, is based on 2 concepts.